the maximum protection possible. First Nations people are experiencing severe and significant effects of COVID-19, with an increasing proportion of cases and overrepresentations in hospitalizations, ICU admissions, and deaths. Since Friday, January 29th, 261 new cases of COVID-19 have occurred in First Nations people in Manitoba, representing 70% of all new cases in the province. First Nations people currently make up 73% of all presumed active cases, 50% of hospitalizations, and 52% of ICU admissions. 5-day test positivity among First Nations people is at 19%. These disproportionate effects from COVID-19 that are being experienced by First Nations people are not due to inherent vulnerability. Rather, this increasing proportion of new cases and overrepresentation amongst hospitalizations and ICU admissions is rooted in long-standing structural factors. This includes overcrowded, inadequate housing and lack of equitable health care that puts First Nations people at higher risk. This means we need to ensure that First Nations people in Manitoba have access to the vaccine in an equitable and timely way, both to protect those most at risk and to protect our healthcare system from being overwhelmed. Because of the strong collaboration between First Nations, Manitoba Health, and FNIB, we have excellent First Nation-specific COVID data, and that has guided our public health response and is informing the vaccination plans. To date, 5,300 doses of the Moderna vaccine have been allocated to First Nations communities, with an additional 5,300 doses to be provided in mid to late February to be used as second doses for these individuals. Vials have been shipped to all 63 First Nations communities to vaccinate healthcare workers in remote and isolated communities, residents and staff of personal care homes and elder care facilities, individuals 60 and over in remote and isolated communities, and individuals 70 and over in all other First Nations communities. It is important to note that First Nations people who meet any current provincial eligibility criteria, such as healthcare workers in the specified categories, will continue to be able to phone and book appointments as vaccine is available at the provincial super sites. Today, I can confirm that an additional 1,200 doses of Moderna have been made immediately available for further First Nations prioritizations. These vaccines will be used for several new priority groups. This includes healthcare workers in non-remote First Nations communities. This is to ensure that these important healthcare workers are able to access appointments at the super sites even while the Pfizer vaccine is delayed. Eligibility includes healthcare workers with direct patient or client interaction, such as doctors, nurses, healthcare aides, home care workers, medical transportation drivers, and other direct service providers. Vaccines will also be made available to First Nations alternative isolation accommodation workers at those sites that are managed or supported by First Nations organizations. Finally, traditional healers and knowledge keepers will be able to access the vaccine, whether they met previous age criteria or not, and including those who live off reserve. This is to acknowledge the key role that traditional healers and knowledge keepers play as part of our health workforce. Within this group of traditional healers and knowledge keepers, we would include people who are recognized and respected ceremonial leaders, people who are recognized and respected healers who use ceremonies, plant medicines, touch, or other healing modalities, and people who are recognized and respected knowledge keepers who are leading and passing on cultural teachings and practices for the health of our communities. The additional 1,200 Moderna doses will be available through a pop-up site in Winnipeg and also potentially at hubs in Thompson, The Pas, and Flin Flon. Where the number of eligible healthcare workers is high enough, vials may be shipped directly to the community. We are actively working with the task force and logistics teams in operationalizing this plan. We expect that these doses will begin administration at a Winnipeg pop-up site on Monday, February 8th. I want to note that work will also continue with the Vaccine Implementation Task Force to ensure equitable access within the broader provincial vaccination plans. This includes ensuring younger First Nations people are able to access the vaccine sooner, both on and off reserve. The life expectancy of First Nations males in Manitoba is 68 years, which is 11 years less than for all other males in Manitoba. The gap for females is also 11 years, with a life expectancy of 72 for First Nations females, compared to 83 for other females in Manitoba. In addition, the median age of severe outcomes from COVID for First Nations people is also much younger than it is for other Manitobans. The median age is 51 for hospitalizations, and the median age of death is 66 for First Nations people in Manitoba, which is a full 17 years lower than the rest of the province. As I've mentioned previously, First Nations people make up 50% of hospitalizations currently and 52% of ICU admissions. We will address these gaps by ensuring that younger First Nations people have access to the vaccine sooner to address this higher risk for First Nations people. As such, in Stage 2 of the province's vaccine rollout plans, when Manitoba begins the vaccination of individuals over age 80, we will begin the vaccination of First Nations people over age 60. If we applied the same 80-year-old cutoff for First Nations people, the result would be that First Nations people would be disadvantaged and would not have the benefit of equitable protection that the vaccine would bring. When Stage 2 begins, First Nations people over the age of 60 will be able to access the COVID-19 vaccine. And as the province starts vaccinating at over age 95 and then descending in 1-year increments, we will begin with those over age 75 and then again drop by 1-year increments. This will ensure the higher levels of risk experienced by First Nations people at younger ages is adequately addressed. In congregate living facilities, the proportion of First Nations individuals will also be taken into account to ensure that the higher levels of risk experienced by First Nations people is adequately addressed. For example, the same pattern of long-standing inequities in the social determinants of health and other impacts of colonization and structural racism that contribute to risk of COVID-19 also lead to overrepresentation of First Nations people among those experiencing homelessness and in correctional facilities, settings which have already experienced outbreaks. As one example of this, a focused immunization team will visit Kikkonen Centre, an assisted living facility for Indigenous seniors in Winnipeg, to offer first dose immunizations this week. Our next steps will include focusing planning on how to support urban Indigenous populations. We know First Nations people are more at risk of COVID-19. We know that there are many factors related to colonization and systemic racism that have led to this heightened risk. We have worked hard to build a strong relationship to bring forward high-quality evidence to inform and structure Manitoba's vaccine immunization plans to help address this risk.
Thank you, Dr. Anderson. So a great deal of work has gone into developing these plans through the leadership of our First Nations health experts, and I want to thank everyone involved for their thoughtful work, careful consideration of the significant issues First Nations people face. I also want to take a moment to reiterate some of Dr. Anderson's comments. The high number of cases and severe outcomes faced by First Nations people are not because they are inherently more vulnerable. This is because there are significant effects related to colonization, inequities, and inadequacies in our healthcare system. Because of the strong collaboration between the First Nations and government partners, we have excellent First Nations specific COVID-19 data. This has guided our public health response and is informing our vaccine plans. The vaccine plans being announced today will ensure that First Nations people will have the maximum protection possible. I'd also like to take this opportunity to announce some of the additional immunization plans to benefit Northern Manitoba. Over the next 2 weeks, eligible individuals in Northern Affairs communities, including War Lake First Nation, Ilford, York Landing, Thicket Portage, Pikwitene, Lynn Lake, and Marcel Colomb First Nation, Leaf Rapids, and Gillam Fox Lake Cree Nation, can receive their first doses of vaccine. First doses will also be available this week in Churchill to residents of the elder care ward, elders in the community who are age 70 or older, and some of the healthcare workers as well. And as Dr. Anderson mentioned, a focused immunization team will visit Kekenen Centre, an assisted living facility for Indigenous seniors in Winnipeg, to offer their first dose immunizations this week. As a whole, these initiatives will help ensure more Manitobans have access to the vaccine in an equitable and timely way. This will protect those most at risk and protect our healthcare system. The plans outlined by Dr. Anderson and the approach here are not only beneficial to First Nations people who are experiencing disproportionate harms, they are also beneficial to all Manitobans. Currently, First Nations people make up about half of all of our hospitalizations and half of our ICU admissions related to COVID. Access to vaccine supports the wellness and safety of First Nations Manitobans, but it's also important so that we can reduce the COVID-19 strain on our hospitals and allow them to get back to other important services like elective surgeries. We know there is more work to do. We are committed to working with our First Nations partners as they lead the way on how best to support First Nations people in Manitoba. Together, we can help protect First Nations people across Manitoba. We'll take questions in a moment, but before I want to close out my remarks, I just want to let Manitobans know that we also have launched a Priority Populations online calculator today. So this tool, which is available at manitoba.ca/vaccine, lets you enter your age and a few other individual details, and then shows you where you fit in our vaccine rollout. So thank you again to Dr. Anderson for being here today, and we will now open up to questions.
Thank you. A reminder to our reporters on the line, you will have one preliminary and two follow-up questions. Up first this afternoon from APTN, Brittany.
Good afternoon, doctors. I'm just wondering, in terms of the urban population, when looking at that, was there anything different in determining, say, opposed to urban non-Indigenous communities, how the vaccine would roll out for urban First Nations folks?
I can speak to that. In our collaborative planning with the task force, what we've talked about is to look at a hybrid approach. So certainly when urban Indigenous people are eligible to access the vaccine through the provincial super sites, those who are comfortable and able to do so will be able to call and book appointments there. In addition, we are looking at pop-up sites or potentially some community-based sites. Again, this will in part depend on what vaccines are available. We need to work closely with our logistics planners to ensure that all of the relevant storage and security needs are met for the Moderna and Pfizer vaccines. But as some of the newer vaccines that get approved and are more widely available can be given through doctors' offices or pharmacists, those options will be greater as well. And so we will be having that mix of both the mainstream sites and perhaps some Indigenous community-based, more culturally safe sites.
Any idea on when that would start?
Yeah, that's a very tough question. As you know, we've had disruptions with both Pfizer and Moderna. Right now, we've gotten some estimates through the federal government for Pfizer for the weeks of February, I think it's February 18th and 25th, but we don't have any estimates after that date. And for Moderna, we have estimates for our next delivery, but really nothing after that. So for now, we are planning with the previous estimates we had received from the federal government, but we know that we need to be flexible and that regardless of what our plans are, they may need to change. So I'm not able to give any exact dates because there's so many unknowns around the supply for us right now.
And then just wondering if there's any updates on numbers. I know that the 5,300 Moderna doses have gone out, and we did no numbers up until January 20th, but just wondering if we have any updated numbers on how many of those doses have actually been used.
Yeah, so we actually have information as of January 27th. One of the caveats I will bring to this, though, is that Of those 5,300 doses, some of them will have gone to non-First Nations people. So for example, healthcare workers in remote isolated communities who are non-First Nations may have received some of those doses. At the same time, some First Nations people have accessed the vaccination super sites. So for example, healthcare workers who live in Winnipeg and were able to call and book appointments there. And so we're not expecting the numbers of First Nations people who have been vaccinated to exactly match up with that reported allocation. That being said, as of January 27th, actually, there was 387 doses administered to First Nations people, including 27 people who have received both doses of the Pfizer vaccine.
From CTV Winnipeg, Michelle.
Hello. I'm just wondering, of the 5,300 Moderna doses that we already have, how many have been administered already? Do we know this?
I don't know the exact number that have been administered, as I've just explained. In part, that is because some of them didn't receive their doses. The last 3 communities received their shipments on Friday of last week, so they are just getting their programs underway. I know that several communities have completed their vaccination rollout, so have used up all of their allocations. Others are still in the middle or nearing the end of that, so we're in quite different phases depending on when the communities receive their shipments.
Great. I'm also wondering a little bit about vaccine hesitancy. Are you hearing that the uptake might be a little bit different, and how are you making the information readily available for people to decide to consent to a vaccine?
Yeah, that's an excellent question. I would say in the vast majority of communities, we've received feedback that uptake has actually been excellent, and that healthcare workers and First Nations elders are really leading the way in making these informed choices. There has been very active vaccine promotion. So through PRCT, through AMC, the FINISM, MKO Kim, SCO, information has been going out. People may be familiar with the weekly Facebook Lives that we've been doing. I think these First Nations-led communication mechanisms have been the best way to really transmit the validated, reliable information and to counteract some of the misinformation. And in communities where uptake has been somewhat slower, we will work directly with community leadership and health workforce to try to address some of the concerns that are being raised.
Great. And my last one is just about tracking the timeline for second doses. We have heard before that the information from the north, because of the connectivity, isn't updated as quickly. So who's going to be tracking to make sure those second doses are delivered on time for each person?
So even though there may be delays in the entrance of the vaccine administration into the Public Health Information Management System, or FIMS, at the local level, they will know the dates in which vaccines were supplied individually and across the community. And so based on that community level information, we will be planning to administer doses as close to that 28-day schedule as possible.
From CityNews, Jonas.
Good afternoon, doctors. Dr. Anderson, first question for you this afternoon. Thank you very much for joining us here today. As we go through this vaccine rollout, it's becoming more and more controversial, and I think there could be some folks at home that are going to look at this phase 2 and you know, maybe wonder about priority and how we arrived at these. If you could just elaborate for folks at home, if you have someone who's First Nation at 65 versus someone who's non-Indigenous that's 80, I mean, are the outcomes similar, or what are we seeing in this pandemic that has led to this decision?
Yes, thank you for that question, and I really welcome the opportunity to reinforce that messaging, because I'm sure you're correct that some people will look at that and at face value say that seems unfair. So I think when we're looking at any type of policy or program or public health intervention like a vaccine program, we need to actually look at the outcomes that are currently being experienced and the outcomes we hope to achieve through the program or the vaccine rollout in this case. So for First Nations people in Manitoba, the median age of hospitalization is 51 years. The median age of death is 66 years. And what that means is half of those hospitalizations for First Nations people and half of those deaths are occurring younger than those ages. This is 17 years younger than the rest of the province. So a 65-year-old First Nations person in Manitoba, another way of looking at that, would be carrying the same risk of hospitalization or death as somebody 17 to 20 years older who is not First Nations in Manitoba. What we want to do is close the gaps. We want First Nations people to not be hospitalized at 5 times the rate we would expect based on the population proportions. So if things were fair, First Nations people would be making up roughly 10% of hospitalizations and not 50%. And we would want the age of those severe outcomes to be the same. The vaccine is one tool to help us get there. And so in order to produce equitable outcomes, we have to have equitable allocation. Equitable doesn't mean equal, it means the allocation that is going to get you closer to the equal outcomes that First Nations people are entitled to.
Thank you very much for that clarification, Ms. Anderson. Ms. Reimer, just want to follow up with you as you guys are working together on this and, vaccine delays and rollouts. I guess just maybe walk me through how you guys are negotiating, or not, maybe not negotiating the right word, but discussing, as these delays occur, how we roll it out and how this works.
Well, I mean, the discussions have really been just that, like a partnership table where we discuss our shared interests. Everybody at that table wants the best possible outcome for all Manitobans. And so we're working together to look at what does the epidemiology, what does the data tell us about how to achieve that? Dr. Anderson just highlighted some of the differences in the age that First Nations people are experiencing the severe outcomes. But on top of that, if we think about healthcare utilization, we need to ensure that we're providing the vaccine to those folks who are more likely to end up in the hospital. For them, primarily, because they're experiencing those harms, but on top of that for all Manitobans, because any of us can at any time need that hospital bed for a COVID or a non-COVID related outcome. So it's really essential that at that table we're thinking about all Manitobans, but that we're focusing on how we reach the people who are experiencing the most harms. And our data shows us that it's very clearly First Nations people who are experiencing greater harms at younger ages. So that table has been, a wonderful opportunity to discuss a variety of different priority populations. We've had discussions as well about congregate living facilities, some of which represent the broad breakdown of the population in general, some of which have overrepresentation of First Nations people. And so we're having regular discussions about what we're seeing in those facilities as well, and determining how best to utilize this right now extremely limited supply that we have.
Thank you so much for that. And just as a final for Ms. Anderson, or Dr. Anderson, apologies, ma'am. It is going to be the North, I think, over the next little while that is going to be providing the worst outcomes. Just a statement, I guess, from you on what you're seeing up there and what the data is telling you about the situation in northern Manitoba.
So last week, we did see that of the total number of First Nations cases in Manitoba, I'm just going to flip to that quickly, that more of them were in the north than were in Winnipeg. But up until that time, actually, First Nations people in Winnipeg had also been significantly impacted. And I think it's important to highlight that although right now the North is having a high concentration of cases, that this changes from week to week or month to month, depending on where those clusters or outbreaks are occurring. Right now, I think we're very focused on providing supports to the communities that are hardest hit, because we need to really focus our efforts on that cycle of test, trace, isolate as quickly as we can to contain those outbreaks. I think, we are all concerned that that can change quickly as things reopen in the province, as cases start to rise again, which is what we are anticipating. We need to stay equally diligent, not just in the north, but also in Winnipeg and Southern First Nations as well.
From CHVN, Taylor.
Hi, good afternoon. Just to clarify, can you explain how the vaccine distribution is going to work? Like who decides where doses go, especially if there is a shortage?
Are you asking just within First Nations communities or more broadly? Sorry.
More broadly.
More broadly, okay. It's right now we're focusing on using Pfizer in our super sites, and so that's when you see on our website the eligibility that's gets updated. We're mostly talking about the super sites and a few other locations as well, such as the personal care homes in Winnipeg specifically. When it comes to remote and isolated communities, First Nations communities, and some of the harder to reach facilities, that's where we're talking about Moderna, because while it's still logistically very challenging, it is less challenging than Pfizer. And so we can move it more easily to locations outside of urban centers. When it comes to Pfizer, the decision is somewhat made for us just based on how the manufacturer gives us instructions on how we can use it. But with Moderna, we have more flexibility, although, as I said, it's still logistically very challenging. So most of our discussions have been focused on our Moderna supply, which is quite a bit smaller than the Pfizer supply. I think I've mentioned in the past, we typically get about 7,300 doses every 3 weeks of Moderna. So at the tables, we have information from our epidemiology and surveillance team. We have our First Nations experts. We talk with the medical officers of health. There are many different players who have a role in informing which priority populations are targeted first. So the epidemiology made it very clear that First Nations communities needed to be one of our highest priorities, as well as our congregate living facilities, particularly those with elderly populations. And we also follow the National Advisory Committee on Immunizations guidelines, who also very clearly highlighted these same populations as high priority throughout the country. So there's a number of folks who play into this, and we're trying to consider, the feasibility, the logistics, and the data all at the same time.
And seeing as we're seeing vaccine delays, what reassurances can you give First Nation people that they're going to get their vaccines in a timely manner?
Our commitment is to stay in very close communication collaboration with our provincial and federal counterparts. And as the shipments come into Manitoba, to ship them out to the communities the same way we did with the first round of allocations, so that they can be administered as close to that 28-day schedule as possible. With our planning, we were not anticipating these Pfizer or Moderna shortages. I don't think any of us were, so we may need to have some flexibility, but we have been reassured multiple times by the province that the commitments do stand, and we'll be trying to get them out in as timely a fashion as possible.
And this question's for Dr. Reimer. What's happening with the second doses for the personal care homes? The press release says that they're going to start on February 8th, but we've heard from care homes that they don't have dates yet.
I don't have the exact dates in front of me, but what I can confirm is that the shortages have not affected the end date for our personal care home rollout. So we have enough supply that we'll be able to reach all personal care home residents for their second dose by the original timeline that we set out. We made sure that we prioritized the second dose for this population because we know that elderly Manitobans are less likely to have a strong immune reaction after the first dose. So it was decided to put their second dose needs as our first priority. And then we thankfully, because of the great planning of our planning team here, we really only had to reschedule a small number of our healthcare providers' second dose appointments, and only by a few days. So at this point, we have enough supply of Pfizer to provide all of our personal care home residents and all of our healthcare workers their second dose within the manufacturer's recommendations.
Thank you.
From the Winnipeg Free Press, Dylan.
Hi, doctors. I want to thank you both for taking our questions. This is very helpful for media. I'm just looking for some specificity on two terms. You mentioned that the remote/isolated communities, and you also mentioned the traditional healers and knowledge keepers are going to be people who are recognized as leaders. I'm wondering if you have a list of these remote communities made up already, and who makes the determination on who is the recognized leader?
So with respect to the first question, the remote isolated communities are defined as those that do not have year-round road access. So that list exists. I do not have it right in front of me. In terms of the traditional healers and knowledge keepers, I think what is really important is that we use First Nations ways of recognizing traditional healers and knowledge keepers. So these are people who will be respected and recognized by communities. They may have affiliations with some organizations or not. They may, for example, be knowledge keepers in post-secondary institutions or other organizations like that, as well as with First Nations organizations. But for thousands and thousands of years, First Nations communities and nations have had ways to respect and recognize traditional healers and knowledge keepers, and we will be looking to build on those processes to access and offer vaccine to these really important people.
Thank you. And are either of you aware of any Manitobans traveling to their home reserve in order to access the vaccine, and do you think that's likely to happen?
I can say that we have actually not seen a rush of people going back to their First Nations communities. I will note, though, that First Nations people tend to be highly mobile, and it would not be unusual for people to have dual residences both on and off reserve. So there may be some people who live part-time on reserve and part-time in Winnipeg or Thompson or another area who maybe were able to access vaccines in their communities, but have not heard about mass movement from urban areas to First Nations communities for these purposes.
Sorry, that question was also for Dr. Reimer.
Oh, I have not heard of any individuals going specifically to communities for immunization, but certainly that's something that the First Nations table would be aware of and making decisions around, and I would look to them and their expertise around how best to communicate with folks about the best options for them.
Great, thank you. And my last question is for Dr. Reimer. It's a question that does not only pertain to First Nations. We have a reader who got immunized, but was told that she would have to contact her medical doctor to request vaccination records. The reader says she's probably going to have to do this when she's traveling for work. She said this will only add to the backlog of the physicians that are already overworked. So I was just wondering why Manitoba doesn't issue vaccination cards up front for COVID.
So right now, the best way to get access to immunization records, whether it's COVID or any other immunization, would be to contact your local public health office rather than your primary care provider. The public health office can access the entire registry of immunizations going back to 1981. So for those who are in Manitoba back to that time period, all of those immunizations are available at a public health office. In regards to a card, we are looking at a few different options right now. So we have teams who are exploring some online or some card options to make it easier for Manitobans to get access to their own information going forward, but I don't have any updates as far as which direction we're going to end up going or what date to expect it to roll out.
From Global News, Kevin.
Good afternoon. When you talk about stage 2 of the province's rollout plans where you'll begin offering vaccination to people over 80 and First Nations people over the age of 60, will you want to make sure this happens at the same time, or will you potentially begin, depending on supply, I guess, will you potentially begin vaccinating First Nations people over the age of 60 first, or do you want those timelines to match, basically?
I think our goal would be to have them match as much as possible. Based on supply, what we've said right now is that we're going to start with Manitobans over 95 and First Nations Manitobans over 75, and then move in 1-year increments as supply comes in. If the supply were not even large enough to go to the 95 and 75, we could consider having even higher age limits, but certainly we are hopeful that based on the estimates that we had previously from the manufacturer, that we would be able to start at those ages concurrently.
Okay, and how have the most recent news of the potential Moderna delays, how has that impacted this plan that you've put together? Did it kind of leave you scrambling, or has the plan been left almost as close to the same as possible before that announcement?
I would say right now we don't know. We haven't gotten any adjusted estimates for our Moderna supply. We've been told about the next shipment, but beyond that, right now there's no information available to us. So we are not right now adjusting our plans. We're moving forward assuming that the previous commitments are going to be the same ones that we can expect. But you know, our table is very aware, all of us are very aware that vaccine supplies are unpredictable and that we will all need to be flexible. And it's entirely possible that we may have to shift things as we go forward because we obviously can't give vaccines that we don't have.
And I know you don't want to touch too much on timelines, but I'll ask anyway, if the dose numbers kind of get back on track to where you thought they were going to be, can you answer, like, when could everyone in the First Nations communities who wants the vaccine, when could they possibly get it by?
In First Nations communities specifically, I mean, I don't think that I have any ability to give timelines that broad. I would say that right now our plan in March would be to start doing the age-based approach, which would include all Manitobans, including First Nations Manitobans with that age differential. The Moderna supply, I'm not sure how to give an estimate because we truly don't have any information beyond our next shipment. So it's very challenging for me to give any sort of date as to when we might be able to provide enough vaccine to cover all First Nations communities.
If I could add one thing to that, what I would say is that in addition to the vaccine supply, we need to continue to be responsive to what the evolving information and data is showing. One thing I will let folks know is of the 135 deaths that have occurred in First Nations people, 92 of those have occurred in the off-reserve population. So with the personal care home vaccinations being completed, one of the concerns we might have is that actually First Nations people would become relatively overrepresented, even more so amongst severe outcomes, including death. And if those continue to be at younger ages, I think what we've determined through our partnership with the province to date around vaccine planning is we can shift plans to respond to needs. And so I would consider that something that remains on the table if we do need to accelerate at younger ages for First Nations people to respond to the evidence-based need according to what the evolving evidence shows.
From the Brandon Sun, Michelle.
Good afternoon. Dr. Anderson, my first question is for you. I'm not actually certain the general population in Manitoba understands overcrowding at First Nations. Can you explain what that looks like, the impact it has normally, and then take it into the pandemic, please?
Yes, and thank you for that question. I'd love the opportunity to talk about that a bit more. So the first thing that I would say is overcrowding occurs both in urban areas as well as in reserve and remote First Nation communities. And so over the long term, what we've seen in previous respiratory illness outbreaks, for example, H1N1, is because viruses are spread more easily when you're in closer contact with people. The more people you have in any space, especially a home, the more that virus is going to spread. And so every year we see more influenza amongst First Nations people. During H1N1, we saw more H1N1. We still have ongoing tuberculosis outbreaks in First Nations as well as Inuit communities. That is largely driven by overcrowded, inadequate housing, and then worsened by other factors like income insecurity, food insecurity, higher rates of underlying chronic illnesses. So during COVID-19, during this pandemic, one measure that I would point people to is the secondary attack rate. This is the percentage of close contacts to a case of COVID-19 who go on to become a case. And although I haven't seen the updated numbers recently, no reason to think they would have changed over the last month or two. In First Nations people, that secondary attack rate, so the percentage of people who are close contacts who become cases, is over 40%. And in general, this had been closer to 10% for the rest of the province. And having worked directly with many different First Nations communities experiencing cases, clusters, outbreaks, I can say it's not been unusual where we're talking about households with a single bathroom, 2 or 3 3 bedrooms where double-digit numbers of people are living, 10, 12, and in some cases over 20 people living. So I think if we want to imagine the province's usual advice, which is best case scenario, have a private bedroom and have a private bathroom to isolate in, when you're in the double digits in a single bathroom household, that is going to be almost impossible. And that is what drives a lot of the spread that we see in First Nations communities.
Okay, thank you for that. My second question is a little bit more philosophical. So how can the press or even the public better serve First Nations in these times, as they are disproportionately affected by this pandemic? What can we all do?
Well, I really appreciate that question as well. I would certainly encourage the media, as you have been doing, to continue to report on our weekly bulletins that PRCT puts out in terms of how First Nations people are being impacted by COVID-19, because that sets the foundation for discussions like today, where it's not going to be news to anybody in Manitoba that First Nations people are being disproportionately impacted, because we've been sharing that information for months now. I think sharing the reliable sources of valid information about the vaccines, so the up-to-date scientific information, how well tolerated they are, to correct any misinformation, that's a really important partnership as well. And the third thing I would say would be to highlight the very positive success stories, the community leaders who have taken very proactive measures like check stops and other community level measures to try to protect communities, the ones who have implemented additional public health orders. Peguis had done that, Little Grand Rapids had done that, Cross Lake had done that, now Pangasi, who are really working closely with the province and with their health workforce to contain these outbreaks. I think highlighting First Nations strengths and First Nations leadership in the response helps us all see not just the deficits and the disproportionate impacts that are the outcomes of colonization and structural racism that we have collective responsibility to address, but the importance of First Nations leadership and excellence in leading the way in responding.
Thank you, Doctor. Dr. Reimer, my third question is for you. Métis have similar, possibly worse health outcomes than First Nations. What is being done now for Métis?
So when it comes to COVID specifically, we have excellent First Nations related data. We don't have the same data related to Métis populations. But that said, I understand that the Minister of Health, Minister Stephenson, has reached out to Minister Chartrand and that they have some ongoing conversations about partnerships there. And the MMF is participating in our communications table as well. And as Dr. Anderson mentioned, we're going to be moving into work in the very near future on our urban Indigenous populations, and the Métis and Inuit leadership will be essential to be part of those discussions as we move that forward.
Thank you.
From the Winnipeg Sun, Nicole.
Both of you are doing well today. I know you have spoken a little bit about this before, but I think you noted that the first doses will be available this week in Churchill, and over the next 2 weeks, eligible individuals in Northern Affair communities can receive their first doses of vaccines. So I was wondering, could you share specific dates and exactly how many doses will be delivered to these communities, as well as how many will be offered to the Kokinan Center?
Well, so for Churchill, I believe there's doses that are on their way up, possibly as soon as today, although I don't have the exact information in front of me. In Churchill, they are going to be offering doses to individuals who live in their elder care facility, as well as elders in the community who are over 70, and eligible healthcare workers as well. The exact number, I would have to ask our communications folks to get back to you with that. For the other communities, there are a variety of communities, and we work with them to find the best possible dates to ship the doses up. So each community may have a different date depending on when they have staff available, when it makes the most sense for them to have those doses go to the community. So it's not that there's one specific date where all of these communities are going to receive their next doses. I don't know, Dr. Anderson, if you have any other information on any of those. Oh, Kekkonen as well, you asked.
Kekkonen is having a fit team this week, is what we were told. The only thing that I will add to that is that there is a really excellent logistics team, both in the province as well as First Nations planners and our FNIB partners, with the North, particularly Northern Regional Health Authority as well. It's incredibly complicated, and I just would offer my thanks to them for the long hours that they do in setting these up. It was an incredible effort to get the doses out to 63 First Nations communities within the time frame that they did. And so I have full confidence that with these Northern Affairs communities, they will also be having them out in an incredibly timely fashion.
And my second question is, do you think that the rollout to these northern communities will go as planned, or do you expect there might be some delays, or maybe the rollout could even be allocated earlier?
When we rolled the doses out to Northern First Nations communities, there were delays at time, and in part because some of those communities require plane travel to get the doses in, and also helicopter transfers from airports that are over water from the nursing station, for example. So in a number of situations, doses were delayed because of weather factors, for example. So on a community by community basis, it's impossible to predict where there may be delays. But like I said, the logistics planners and all of the transportation folks will do their utmost to get them out as timely fashion as they can.
And even though, could you speak more in detail? Because before you said that, the weather could be a factor that the rollout could be delayed. Are there any other factors that could be, factoring the delay?
So the other factor that we really had to pay attention to was the shipping containers. So Moderna, it's preferable to ship it in the frozen state. And so the number of shipping containers in the province that can then be sent out to the communities to ship their doses also needs to be taken into consideration. And then I would defer to Dr. Reimer on any specific plans because I think the other element will be whether there is local health workforce who are administering the vaccinations or whether there is additionally fit team planning that needs to go with the communities for their vaccination programs as well.
I would agree that the logistics are incredibly complicated. There are so many communities and they each have very unique needs and unique setups. And so we've been partnering with the federal government, with Ongamas and Health Services, because there are different setups that we need to acknowledge and prepare and provide different resources in different circumstances. So there are times where the province can ship just the vaccine and no other resources are needed. But there are other times when we need to supply health workforce to be able to do administration. So there are a huge variety of different factors that can lead to delays. But what I would really just commend the team on is the very small number of delays that they experienced. I think the weather delays were the most substantial that we saw. So it's really been impressive to watch the team in Winnipeg and the teams throughout all of the communities in Manitoba navigate this brand new situation so well.
All right, thank you so much.
From CBC Radio Canada, Camille.
Hi, doctors. Je vais vous poser des questions en français pour Radio-Canada. Premièrement, en lien avec la communication, vous l'avez dit en anglais, il y avait une déconstruction de certains mythes à faire, donc des campagnes de communication. Je voulais simplement savoir comment en ce moment ça se passait. Est-ce que les communautés maintenant réagissent pour la plupart très bien à l'accueil du vaccin?
Je suis désolée, c'est trop difficile d'entendre. Est-ce que vous pouvez poser la question en anglais?
Yeah, sure. No problem. Hold on. Yeah, I wanted to know regarding the myths that were around the vaccine right now, were you able to change the perspective for a negative perception about the people in the communities, in the First Nation? Like, how is it going with the communication campaign that you did on Facebook? I just want a little wrap up. Is it possible to answer in French?
It is not possible for me to answer in French. I apologize. I will go ahead and answer in English and perhaps can be translated afterwards. In general, communication campaigns have been effective. I think one thing that's really important and beneficial about social media is that when people make comments or ask questions during something like our Facebook Live, we have the opportunity to address it right then and there. And because of our extensive networks through our multiple organizational partners, as well as our solid relationships with the health workforce, including the health directors, we are able to hear directly about some of the concerns that are arising. So work's certainly still underway. One of the things that's been really effective is having elders share their experiences with other elders. And so in one community in particular, there was a situation where they had multiple elders withdraw their consent, but then a few days later, after they'd heard from their peers in the community who had been vaccinated, who had minimal side effects, they were able to be rebooked and then be vaccinated. And I think that really speaks to the importance of peer-to-peer information sharing as well, whether that's elders to elders or First Nations people in general. And it's probably something that as vaccine rolls out more broadly, we would want to look at for other communities as well.
Thank you for that. And for my second question, how do you welcome the agreement signed between the federal government and the Manitoban government for the support airline in the north? Does that help the plan, and how does that help?
Sorry, which agreement are you referring to?
We received a press release regarding an agreement signed between the government to support the airlines in the north.
We would have to take that question away and have somebody from communications get back to you on that.
All right, this was this morning. And my last question, does the vaccine administered in the New Thompson site are from Moderna? I just want to confirm. And for how long will this brand of vaccine will be administered there?
So for now, we're using Moderna in Thompson because we were experiencing the Pfizer disruption. The long-term plan would be to use Pfizer in Thompson once the supply returns, because we wanted to use it similarly to Winnipeg and Brandon as a super site, as well as having the airport available for people who can fly to the vaccine. So right now, the plan for this immediate rollout is to continue using Moderna, but as soon as we have more information from the federal government on what we can expect for Pfizer, we will be switching to Pfizer.
From CBC Manitoba, Ian.
Good afternoon. First of all, just maybe on a point of clarity, we are sort of looking at a 20-year age differential, 80 years if you are, general public, 60 years for First Nations. Are we expecting to go down by sort of 20-year increments all the way down?
That age differential will continue to apply across all age increments. So yes, when the province is doing, for example, 60-year-olds, we would anticipate First Nations people over age 40 being eligible and so on.
Okay. There are plans in place involving urban Indigenous and Métis and Inuit people to get them involved. Is the plan that, say a 40-year-old that is on the First Nation would get the vaccine at the same time as a 40-year-old that is Métis or living in an urban center? Is the plan to treat those demographics equally?
That is certainly the ideal scenario. I think people are aware that we were able to proceed with community dwelling elders age 60 or 70 and over in First Nations communities prior to off-reserve or urban First Nations people of the same age groups. And in part, that has to do with healthcare availability in our planning. So we certainly did factor in how far away people were from tertiary care in the event that that becomes necessary in making that decision. I would say from a First Nations perspective, we're very concerned about that. And one of our high priorities in collaboration with our federal and provincial partners is to equalize that as soon as the vaccine supply allows. We do want to see First Nations people living off reserve with the same access to vaccine as First Nations people living on reserve as soon as possible.
Thank you. There was a bit of to follow up on that, there was a bit of a backlash from, urban Indigenous people, that they were not being considered for the vaccine right away. Did that criticism, did that sort of influence the plan that we have now? Or was, as you noted, was it just a matter of practicality?
I would say we certainly heard those messages, but that wasn't the shift in the plans. Officer First Nations people have been a high priority for us the whole way through, in part because of what our data shows, and as I've mentioned, Officer First Nations people having the same risks in terms of more severe outcomes, being overrepresented in hospitalizations, ICU admissions, and deaths. And I think it's important to realize, as First Nations health experts, many of us have older relatives who are living off reserve. We have a very vested interest in this as well for multiple reasons. So we certainly welcome the advocacy from other corners as well. We certainly welcome that message getting out, but that builds on messages that we were already bringing to the table.
Our final reporter this afternoon from the Canadian Press, Kelly.
Hello. So you mentioned obviously that you're making some plans for disruption around the Pfizer and Moderna vaccine, but especially the Moderna vaccine. Is there any kind of plan for rollout? I know the feds have said that they expect more sustainable vaccine distribution come March and April. Are you making plans around that, and what does it look like?
Yeah, I mean, we're absolutely making plans around the hopefully expanded numbers that we're expecting to see in March for both Pfizer and Moderna. That's why we mentioned age-based eligibility, for example. The previous estimates that we had received from the manufacturers through the federal government indicated that in March we would be expecting to see a substantial increase in how many doses we receive of Pfizer, and that's why we're planning to open up to the general population based on age, hopefully in March. We are still waiting for updated estimates, but the message that the federal government is sharing is that we are still expecting very similar final tallies at the end of the first quarter of the year. And so we're making plans according to that. Likewise, for Moderna, we don't have those updated estimates yet since the disruption occurred, but also we're hearing reassurance from the federal government that the manufacturer is indicating we also should be expecting that the numbers will resume and increase in March as well. And that's exactly why we're at our table starting to talk about things like our urban Indigenous population and the large variety of congregate living facilities throughout Manitoba that would be better served by Moderna compared to Pfizer. So all of those groups are where we're focusing our attention right now and going into March.
So you've mentioned multiple times that 5,300 doses were allocated for First Nations communities. Can you explain a little bit? Obviously, some of the communities you mentioned just got their doses on Friday. I think we've seen some video and footage of them being handed out. But can you explain a little bit about the challenges of getting these vaccines to these specific communities that might result in a couple-week delay or even a few-day delay despite getting the vaccine, actually getting them to the right people?
Sure, thank you. So we've talked about the logistic challenges and the need on a community-by-community basis to plan the shipping containers, the land transportation, and the air transportation, sometimes two forms of air transportation, to get the vials themselves into the communities. We had one community, Cross Lake, for example, that posted pictures of them administering their first doses the same day that they received the vials. So there's not always a delay there. But one thing that I will note is that in several of these communities, they are now rolling out a vaccine program at the same time that they are managing the public health work of active COVID cases in the community. And these have quite finite health workforces in the communities. And so I just really want to congratulate them on the speed that they have been able to administer vaccines vaccines in places, for example, like Garden Hill First Nation. I can't comment specifically on the number of doses, but they are a community that is well known to be dealing with a high case count, has support from multiple partners, including the Canadian Armed Forces in the community, and at the same time has been vaccinating people according to those eligibility criteria.
And I think it's been noted that this is obviously the largest and possibly most complicated vaccine rollout strategy across Canada in history. But what lessons have you learned, I guess? It's been a few weeks now since Moderna was approved. What lessons have you learned in your experiences so far rolling out kind of this first batch of doses that you will take on to the next months as we get more out there in the communities?
Mm-hmm. So I anticipate, the second rollout of the 5,300 will be somewhat easier because we have those templates in place now. They have more information about the transportation logistics for each community, and it's a fairly fixed population. It's everyone who's received the first dose who needs to be brought in for the second dose. So I do anticipate that will go smoother. And then I think further to that, as we look at increasing the number of doses with the broader population rollout, we want to look at some of our other successes as well. And Dr. Reimer mentioned some of those. So Ongamasin Health Services, as an example, on behalf of PRCT, has been deploying these First Nations rapid response teams. And that's been a really good partnership across jurisdictions and organizations, including tribal councils, for example, and regional health authorities to deploy workforce where needed. And I think that's one of the examples we can build on to meet surge capacity needs in First Nations communities for wider rollouts of the vaccine. So I think those are some of the lessons as well we want to bring into our future planning.
Thanks, everyone. This concludes our media briefing.